my name is Dr. James Conway. I'm a pediatric infectious disease specialist here at the University of Wisconsin-Madison in the School of Medicine and Public Health. I've been a pediatric infectious disease specialist for over 30 years and have spent much of my career trying to prevent infections that have unfortunately devastated children and populations across our country and across the world. Today, I'm going to be talking to you about understanding the ACIP meningococcal vaccination recommendations. Our learning objectives today are to discuss the significance of meningococcal infections, to review the adolescent immunization coverage rates here in the United States, to summarize the current ACIP meningococcal vaccine recommendations, including our target age groups, and then apply these ACIP recommendations to clinical practice. As most of you know, meningococcal disease is an often serious and rapidly progressive infection that leaves little time for diagnosis and treatment. Early in the course of these illnesses, people can present with symptoms that are similar to many common viral illnesses and often start out with flu-like symptoms, which can make the diagnosis difficult or at least delayed. Once that diagnosis is made, unfortunately, sometimes these infections have already progressed, and unfortunately, the devastating effects may not be able to be avoided. Neisseria meningitidis is now the most prevalent etiologic agent of bacterial meningitis among children and adolescents 2 to 18 years of age here in the United States. This is largely thanks to previous vaccinations, including the pneumococcal and Haemophilus influenza vaccines. Meningococcal vaccine is the next and the most important now in managing and preventing these devastating infections. While people are mostly concerned about the fatalities related to meningococcal disease, the survivors, unfortunately, suffer from long-term sequelae that are frequently quite devastating. Meningococcemia, when Neisseria meningitidis is just found in the bacterial bloodstream, can cause skin scarring, limb loss, renal failure, septic arthritis, pneumonia, epiglottitis, pericarditis, and numerous other infections, depending on where those bacteria land. Those cases have fatality rates of up to 40%. Meningitis, which I think is the more commonly understood, can also cause significant morbidity and certainly mortality with spastic quadriplegia, hearing loss, cerebral infarcts, cortical venous thromboses, cerebral edema, cranial nerve palsies, cognitive impairment, and hemiparesis. And while these cases are less likely to be fatal, the devastating effects of these can be lifelong. So let's talk about meningococcal prevention then. I think it should be clear that the most important way we can manage meningococcal disease is to prevent meningococcal disease and prevent all meningococcal infections. Every adolescent deserves to be protected against this unpredictable and potentially devastating disease. And meningococcal vaccination is recommended for all adolescents. Starting the ACY and W vaccination at age 11 to 12 is important for adequate protection during the times of greatest risk. Men-B vaccines, while are under shared clinical decision-making, should be discussed with everyone and recommended for the majority of our population. We strongly recommend that you follow the recommended ACIP and CDC immunization schedule to ensure that your patients get the vaccines that they need. Briefly, I think we should talk about the history of adolescent immunizations. In 1996 was the very first time that ACIP, AAP, AAFP, and the AMA actually even recommended a healthcare visit as a routine occurrence for 11 to 12-year-olds. Before the year of 2005, immunizations for adolescents were basically administered for catch-up or special circumstances, largely related to vaccines they missed as younger children, with the exception of influenza vaccines. In 2006, the National Immunization Survey first started collecting immunization information for adolescents in this 13 to 17-year age group, and that's because in 2006 and 2007, ACIP and the CDC first created what we now know of as the Adolescent Immunization Platform. 2005 and 2006 was the year that Tdap vaccine, MCV4 or meningococcal ACYW vaccine, and HPV vaccines were all added to the ACIP schedule. And then in 2015, ACIP recommended the meningococcal B vaccines. But I think it's important to realize we've been recommending these vaccines now for over 20 years and for the Men-B vaccines for over 10 years. These should be routine care and routine in every practice. This is data from the CDC from the Mortality and Morbidity Weekly Report, which looks at adolescents age 13 and immunization rates across time between 2015 and 2023. It may look a little confusing that the dates here are actually their birth years, But if you go from left to right, this is 2015, this is 2023. Up here, you can see our meningococcal vaccine rates for one dose for VFC and non-VFC adolescents and Tdap vaccines, and noticing that HPV vaccines lag behind. But you can see the variability of these, and most concerning is the fact that very few of these vaccines actually exceed 90% immunization rates. Again, we really feel that every adolescent should be immunized, and until we get to 100%, our work is not done. So let's start with the quadrivalent vaccine, men A, C, Y, and W. The routine recommendation is that this is a 2-dose series, first administered at age 11 to 12, and then a booster dose given at age 16. If those vaccines are not given at age 11 and 12, a first dose should be given between ages 13 and 15, and then a booster is still indicated for ages 16 to 18, with a minimum interval between those vaccines of 8 weeks. If that vaccine is not given and is only initiated after age 16, then just a single dose is required. There are certainly special situations to be aware of, and obviously college students are a group, as well as military recruits who live in close contact with others. And so a recommendation still is out there that we may administer, and I believe should administer, a dose if an adolescent did not receive it at one of those earlier opportunities, who are going to be in those residential housing settings or in those military barracks. Men A, C, Y, and W vaccines are generally considered interchangeable, so you don't have to repeat the series, nor do you have to do a lot of work to try to figure out which dose they got originally. There are also special situations that add an additional level of concern, and those children with these conditions certainly should be considered for vaccination as well. And these indications go down as early as 2 months of age. This includes anybody with functional or anatomic asplenia, including those with sickle cell disease, those who have some kind of persistent complement component deficiency, or who take a complement inhibitor such as eculizumab or ravulizumab, people who are living with HIV infection, microbiologists who work with meningococcus in a laboratory, outbreaks in any kind of setting that are caused by a vaccine serogroup, and then residents or travelers to certain countries. These high-risk special situations also require boosters, and we know that those are not given as often as they should be. A booster at 3 years after that initial vaccine, and then every 5 years while that risk persists. And this includes throughout their entire lifespan into adulthood. Moving on to the serogroup B meningococcal vaccines. These are in a little bit different category, largely because of the shorter duration of protection that these offer. Currently, data suggests that the immunologic protection from meningococcal B vaccines is probably most robust for about 1 to 2 years. And so because of that, these are listed under a shared clinical decision-making paradigm by the ACIP, and primarily given to adolescents in the 16 to 23-year-old age group who are not at high risk. The preferred age to do this is later in secondary school at age 16 to 18, in preparation for many of these individuals then moving into these congregate living settings. These vaccines are currently licensed by the FDA for ages 10 to 25, and it's important to note that unlike the quadrivalent men ACYW vaccines, these vaccines are not interchangeable. Each of these is a very different construct, and so only need to be continued and boosted with that same vaccine. Bexsero from GSK has 2 doses that are now recommended to be given at 0 and 6 months. People may be aware that those used to be given at a shorter interval, but this was extended after more data emerged. However, people that received those doses at 0 and 1 month or 0 and 2 months do not need to get an extra dose to be considered up to date. Trumenba from Pfizer is 2 doses that are given at least 6 months apart. If that second dose is given earlier than 6 months, those patients do need a third dose to be given at least 4 months after that second dose. This vaccine was originally licensed as a 3-dose regimen, but was back down to 2 doses as more data emerged. There are also currently 2 pentavalent vaccines that include A, B, C, Y, and W strains, one called Penbrea from Pfizer, the other one Penmenvy from GSK. Again, you need to keep within that vaccine class if you're using those in conjunction with the Men-B monovalent vaccines. These are also licensed for ages 10 to 25 years of age, and currently ACIP recommends those when someone is due for their Men A, C, Y, and W vaccine and due for their MenB vaccine at the same visit. We're hopeful that those indications will be expanded in the future, but for now, those are the ACIP recommended times when those vaccines can be used. Meningococcal B also has special situations that put people at higher risk for having infection or complications, and these include people that are 10 years and older with functional or anatomic asplenia, including those with sickle cell disease, as well as those who are 10 years or older, again with persistent complement component deficiency, who take one of the complement inhibitor drugs. People who are ages 10 years and older and exposed during an outbreak also are eligible and should be immunized with meningococcal B vaccine, again with the full 2-dose series, and then microbiologists who work in laboratories with meningococcal isolates. Again, on these meningococcal B vaccines, Bexsero is 2 doses given at 0 and 6 months, recently changed by ACIP and FDA based on further data. Trumenba is a 3-dose series at 0, 1 to 2 months, and 6 months, but can be given as a 2-dose series. And again, Bexsero and Trumenba are not interchangeable. For those who remain at high risk for their condition that puts them at risk either for MenB acquisition or MenB complications, they should get a booster dose 1 year after the series completion, and then after that, another booster dose every 2 to 3 years. Currently, the pentavalent vaccines, Men A, B, C, Y, and W, are not recommended to be used for these routine boosters. Let's talk about supporting immunizations in general, and in particular, our meningococcal vaccines. Here's some key messages about vaccination that I think are important to remember. Vaccination is one of the most important ways parents can keep their children safe. Vaccines are safe and are closely scrutinized to make them safer, and we all know that the disease risks are much, much greater than any risk there is with a vaccination. Parents and providers need to remember that a decision to withhold vaccination from a child is an active decision to subject that child to the risk and the dangers of that disease. Every person deserves to be protected against meningococcal disease. Offer them at every visit, even when they've been previously declined. People change their minds. They hear stories. They are open to these discussions. Routinely start the Men ACWY vaccine at 11 to 12 years and offer Men B to everyone at age 16 to 18. Remember that increased risk means that these vaccines are routine, even for the meningococcal B vaccine. And remember to provide boosters to these high-risk people routinely, ideally throughout their lives if that risk continues to persist. Use every opportunity to immunize. These are not just things that to be given at well visits, but at many other visits when people have contact with the medical system. And think about using reminder and recall programs to ensure that not only people complete the series, but the people that need boosters also have opportunities to be reminded about their need to get those boosters. Thank you for your attention. Please scan the QR code to give your feedback and take a short survey. And thank you for joining us.